Thanks once again for all of you for coming. I appreciate that, and we're very lucky today to have a nurse practitioner and a physician from the Lincoln Physician Group right around the corner from us. So we have Dr. Pamela D. Luca is here, and Kayla D. Tommaso, nurse practitioner, is here, and they're going to be doing a presentation on osteoporosis and bone density. So thanks a lot.
Thank you. Thanks for having us. So we're going to start our talk on osteoporosis. So just to start, this is a picture of a woman who you can see here, and as she's kind of progressed through different phases of life, you can notice there's some change in her spine. This is related to osteoporosis. You can see kind of at the far left here, the spine is nice and straight, and as the years go by, that becomes a little bit more curvy, and it's due to osteoporosis, and we'll talk in more detail there. So what is osteoporosis? It's a bone disease characterized by loss of bone mass and weakened bone structure. Because of that, it makes you more susceptible to breaking your bones or a fracture. Similarly, the radiologic definition, so a skeletal disease with sufficiently reduced bone mass and deterioration of bone structure. So if you take a look at the picture here, this is a nice healthy bone. You can see the connections are thick here. The bone is not as brittle as to the right here. We've lost a lot of the connection. The bone is brittle and making it more prone to fracture there.
Can everyone hear me? Okay, good. So here is kind of a fancy slide, but the big picture and why we lose bone is that we are constantly breaking down and renewing our bone every day. We replace, I think, a quarter of our skeleton over the course of a year. And the reason for that is bone wears out. Cells die that make the bone. With wear and tear, there could be micro cracks in our bone. And also calcium is a vital chemical message to all the muscles in our body. Without calcium as the chemical signal, muscles won't contract, the heart won't work, the brain won't be able to send messages. So we need a source of calcium that is tightly regulated, and that reservoir is the bone. The calcium is derived from the bone. So minute to minute, the body is breaking down a microscopic pit in our bone. The calcium is released, and then a new cycle of bone growth has to begin. So there are the diggers, which have a fancy name here. And so with some stress or input, like physical exertion or trauma, breaking a bone, falling, a crack in the bone develops, these cells sense that. They send a message to the diggers, start digging, want to make new bone. A microscopic hole is literally dug. And then through a series of other chemical, hormonal messages, eventually builders are coming into the area, and then they literally fill in the hole. Now, in our lifetime, when we're children, we're actually building more bone than we're losing. As we reach adulthood, and that's actually 26 to age 30, we've built our peak bones. Our peak bone mass is achieved in early adulthood. And after that point, there's slightly more digging and less filling in a bone over time. When we have menopause, or men later in life, because of hormones dropping in levels, there's a more dramatic loss of bone because there's more digging than there is building back a bone. Why, we don't know. We just call it part of normative aging. And this diagram also speaks to some new drugs that are in development, working on the building versus the digging. So.
Is that better to say?
So this is a woman at age 50. You can see her spine is very straight, and you'll see the difference here at age 80.
Yes, so, and this is the same person 30 years later. It may happen to a different degree to each of us, and some of that is driven by genetics, lifestyle, diet, a whole series of events. But in any case, she has lost height in the vertical dimension because of the process of shrinkage and microfractures in bone, and also some shrinkage of the discs, which are the spacers between the vertebra and your back. And so she's shorter. Because of irregular ways that bone crunches or shrinks as we age and lose bone, there is an accentuation of the pre-existing curvatures. Now, because she shrunk this way, she didn't get fat or gain weight. It's just that the same amount of organs are now occupying a shorter vertical space, making her look a little more pudgy in the middle. A lot of people complain to me about this in their visits, and I don't have a great solution, but the process, you can see, has gone on over 30 years so slowly no one realizes it until they come in one day complaining about it. And the other interesting thing for you to see is her hemline looks a little crooked. That's not her tailor. It's that we get a little curvy, not just front and back from our osteoporosis, but sometimes a little arthritic curves left and right make how clothes even hang on us a little bit different with this aging process.
So there are some modifiable risk factors and then risk factors we can't change. And as Dr. Luca was saying, we reach our peak bone mass at around 26 to 30 years old. So some of the modifiable and non-modifiable. So very low body weight is a risk factor. So that's throughout the lifetime. If you've had low body weight, you're a bit more susceptible to low bone mass or osteoporosis. Older age is a risk factor because we lose a lot of the hormones. Again, like Dr. DeLuca was saying, we lose a lot of those estrogens, and men lose a lot of testosterone that can cause some bone loss there. Caucasian and Asian population are more susceptible. Family history. So if you've had a parent who's fractured a hip, mom, dad, there's evidence to show that that also can have some bearing on your own bone there. Early menopause, again, because you lose the estrogen earlier, can be a risk factor for osteoporosis. Previous broken bone as an adult. These are modifiable, so low calcium intake and vitamin D intake have bearing on your bone as well. And again, cigarette smoking, previous smoking or current smoking, and frequent large amounts of alcohol intake as well. There are also some certain medications that can cause accelerated bone loss, and we'll go over that in the next slide.
So there are many drugs that can affect bone loss. Some common ones are listed here. This is not comprehensive. But heparin is a common blood thinner used mostly in the hospitals and a little bit outpatient setting. Need me louder?
Oh, sorry.
Oh, hold this here. Heparin is a common blood thinner used in hospitals, a little bit less in the outpatient setting, and it was found to cause dramatic bone loss in women in their pregnancy who had blood clotting disorders that had to be on a blood thinner throughout their pregnancy. So that's where it was first known. People who are not on it for 9 months straight are less susceptible to this as an issue. But loop diuretics is a certain class of water pill used in heart patients, not for blood pressure, but for fluid problems. And believe it or not, that actually has been associated with reduced bone loss. And maybe something that your physician may want to, be more aware of in a decision to screen for bone loss in you if you are on these medicines for years. Cyclosporin is a drug used in transplant patients, and like steroids or glucocorticoids, like prednisone, cortisone, they can influence bone loss in a somewhat dramatic way. Transplant drugs are obviously necessary for the survival of transplants, so we simply have to monitor these people more carefully and treat or prevent bone loss when appropriate. The seizure medicines, these effects are over decades of use. Again, these are chronic disorders that, the medications are necessary to treat the disease, but your physician can also help, hopefully, prevent some of the losses that are promoted by these medications. Is everybody here familiar with the proton pump inhibitors like Prilosec or Nexium and those nice commercials that tell you you can eat your pizza without getting indigestion on Saturday night? Well, there's been recent press about people who just stay on these drugs because they work so well, and they stay on them for years on end. And perhaps maybe we're rethinking the concept of just staying on them indefinitely, because when you don't have any acid in your stomach, we believe this is the effect. You're just not able to take the calcium that's in your diet and adequately absorb it through your stomach and get it into your bones. That's an area of active exploration, so your primary care physicians are trying not to leave everyone on these drugs except for when necessary for long periods of time, like years. There are some alternatives also over the counter that are slightly weaker, but might help suppress these symptoms with less concerning reports of hip fracture and things like that at this time. And the other thing is, if you must be on the proton pump inhibitors, it has been suggested that you take a more absorbable calcium that's less dependent on stomach acid being around, such as the calcium citrate products that you see over the counter. So a common brand is Citracal, but it's calcium citrate if you must be on the proton pump inhibitors. And for some people, they need to be on those medications. So if they are, simply a dialogue with your doctor to make sure that piece, your bone health, is being monitored, because the benefit of that medication, a decision made by your doctor and you, has determined you should stay on it. Well, then we should just make sure that you're not suffering any consequences that are perhaps preventable or treatable.
And just to add, is anybody on an inhaler for asthma, a steroid inhaler? So I get this question a lot. Steroid inhalers don't have the same effect as an oral, like a prednisone. So budesonide was studied at an 800 microgram. So most of the Flovent, Symbicort, Advair don't have enough steroid to actually have effect on your bone. So it's a question we get a lot. These are just some statistics, and osteoporosis is a growing problem. 200 million people worldwide have osteoporosis. Worldwide, there's been 8.9 million fractures. There's meaning every 3 minutes someone breaks a bone. Of that 8.9 million, 2.9 of those fractures are from the United States alone. So this is a huge growing problem. A few more here. Half the women over age 50 will break a bone due to osteoporosis at various sites. Most commonly, we see them in the spine, the hip, and also the wrist are the three most common areas. This one really popped up to us as really important. A woman's risk of a hip fracture equals her combined risk of breast, uterine, and ovarian cancer. So there's a 30% chance lifetime risk of getting a hip fracture. Similarly to shingles, which, has anyone got the Shingrix vaccine? So shingles is a very common problem, but similarly, osteoporosis is 30% of lifetime risk of developing a hip fracture, and there's also a 30 lifetime risk of shingles. So really, they're kind of in the same way there.
Osteoporosis in women. So we talk a lot about osteoporosis in women because we develop bone loss a little sooner than our male counterparts, and also it's a little bit more common in women than in men across the board. So a lot of the data and recommendations were first studied in women but do exist for men. For women, a screening bone density looking for your first ever sign of bone loss is generally recommended at age 65. But certainly if you have other risk factors that you can discuss with your doctor, earlier screening is still appropriate. And different organizations have more loose definitions about what to do for earlier screening. Some organizations will say, well, if you're postmenopausal and you're not on hormones, that alone is a risk factor to get a screening test. So it's something you can discuss with your doctor. But the previously described risk factors like low body weight throughout life, certain medications, a prior fracture, particularly a vertebral fracture, a wrist fracture, any fracture might be a signal to look and see if you have osteoporosis or not. And also there's some diseases that predispose people to bone loss, including certain thyroid conditions and hormone deprivation conditions, and cancer agents, particularly ones to fight breast cancer, accelerate bone loss.
So osteoporosis does occur in men as well. And about 8 million men with low bone mass or osteoporosis in the U.S. We start screening men later just because they lose some of that testosterone, but at a slower rate than women lose estrogen. So we start to screen men at around age 70. Similarly to women, men lose testosterone, as we discussed. There's a condition called hypogonadism, which impacts the bones, so losing testosterone in the body. Similar to women, there are other risk factors, so thyroid conditions, certain medications where we would screen men a bit earlier than age 70. And the lifetime risk of a hip fracture for men is 13%. I'm going to do this one.
Okay.
So this is one modifiable intake that you can help with your bones. So calcium is the cement for your bones here. The recommendation for calcium intake for postmenopausal women and for men is around 1,000 to 1,200 milligrams per day. Some people can adequately get this through their diet. If you look to the right, these are some of the foods listed here and their calcium content in milligrams. For people who can't reach that 1,000 to 1,200 milligram recommended value per day, you can add an additional supplement, so a calcium carbonate, calcium citrate supplement to basically add into make it to 1,000 to 1,200 milligrams. Your total calcium intake shouldn't exceed 2,000 milligrams. There can be some adverse effects, such as kidney stone formation, so really shouldn't have more than 2,000 milligrams per day. And again, just some of the food categories here with their calcium content. Just to tie this in as well, so reading supplement labels is important. Most supplement labels are, the serving size is actually 2 tablets, and commonly we see that someone's taking only 1 tablet a day. So just being cautious and reading the labels on your supplements. And then you can actually calculate your calcium servings using food labels. So you'll see the RDA, which is recommended daily allowance, and it's a percentage on food labels. You'll see it next to the calcium. You multiply that by 10, and that will give you the amount of calcium in that serving. So that's a way that you can calculate on your own.
Vitamin D. We're always avoiding the sun these days. We're wearing our sunblock, and we also live in the northeastern United States. So between all those factors, it's difficult for the sunlight to help us all manufacture D just through our skin, which is one of the places that was commonly cited. They used to say 15 minutes of direct sunlight a day would be enough to give you all the vitamin D you need, but for obvious reasons, I don't promote that among my patients. Also in the winter here in the Northeast, the light is tangential, so it's not even the right kind of light to promote that process. It's also a little tricky to get enough vitamin D from diet alone, but some sources that have been cited are wild-caught salmon, tuna. Milk is fortified with vitamin D, but it's a little photosensitive, so sometimes the bottle may not have what it claims to have, but milk is a fortified product. There's also orange juice and other juice products fortified with vitamin D to have the same amount per serving that a glass of milk will. Mushrooms, believe it or not, have some vitamin D in it. And fortified breakfast cereals and things of that nature, yogurt and the juices I mentioned have vitamin D as well. And vitamin D is actually important in helping your body absorb the calcium in our diet and getting it through the stomach into the bloodstream and into your bone. Calcium is very insoluble. It precipitates out when you look at the brine and the ocean on the piers. It's, these substance that makes the shells of clams. It's a very insoluble ion, so you need usually a little acid to help dissolve it, and you need proteins to help extract that calcium from your stomach and transport it where it's needed. There is a lot of information out there in the news on vitamin D and the proper amount and the proper blood level. The truth is, they're all really interesting concepts when you look at vitamin D on cells, on tissues, in animals. But when you try to translate that into what it's doing in humans with certain blood levels, they cannot establish all of these fancy effects or benefits that are theoretical at the moment. So a very conservative mainline recommendation for now is to get somewhere between 800 and 1,000 international units daily for all postmenopausal women. And that's just to help you absorb the calcium from a standard diet for postmenopausal women. And other effects in higher levels have not been proven at this time. An interesting thought is that there is a receptor that recognizes vitamin D on almost every tissue in our body, even though I can't prove to you today how much do you need to help all those other areas. We can only talk about how there's consensus on it just being beneficial in helping get the calcium to the bones.
Exercise is another way. Does everybody exercise here?
So.
Do some form of weight-bearing exercise. So weight-bearing exercise can help with your bones. That's any activity that's opposing gravity will stimulate the bone. At least 30 minutes of walking 3 times per week is recommended. I know a lot of people like to swim, but that's not considered a weight-bearing exercise and won't have any effect on your bones or help your bones in any way. There's no clear benefit of walking or over running. So walking is, it's not to say that one is better than the other. There's some specific exercises that help with different sites in the bones. So the hip, so the non-weight-bearing high-force exercise. So that's in gyms, there's some leg machines where you can do those leg lifts. There's also similarly hip abductors and adductors, so bringing the hips in and out with, again, those leg machines at the gym there. The spine, so combined exercises, so that's walking and this resistance training that can help with the spine site as well. I see head shaking.
Just be careful with walking.
Oh,
I walk 5 miles a day.
Mm-hmm. That's wonderful.
I walked. I walked fast. I walked heavy. I fractured my tibia. And that was just from walking.
From walking, the stress of walking.
So,
okay.
Be careful.
Yeah. These, so they're all cited from medical sources when it's saying that walking, walking is the recommended, but of course there are situations where, fractures can happen despite.
Was this me? Okay. While the noise goes away. So anyway, osteoporosis is often a very silent disorder, and it's not until a critical amount of bone breaks, fractures, or crunches a little bit, and someone has pain, that they're aware of a problem. So that is the argument for screening before maybe one of those events happens. Sometimes when you do special studies of the spine in postmenopausal women, long before a major event has happened, some women will actually have smaller compression fractures. They might have just thought it was, old age, or they may not have had any pain until a critical event happens, and yet it can be there. So that's the argument for screening with the bone density, to get an overall picture of your risk so that you may choose, after dialogue and discussion with your doctor, what more can be done to slow down, halt, or partially reverse the process. Yeah, this is talking about how 2/3 of vertebral fractures are silent until some major event happens. So.
Or sometimes incidentally noted. If you go for an x-ray of a different part of your body,
you might see it.
Fractures are just kind of noted incidentally. So how do we screen for bone loss? We do a bone mineral density, also called BMD. The technology of the bone density, it uses dual energy X-ray. So it's very small amounts of X-ray. You actually get more radiation exposure on a flight from here to Colorado, or just even outside sources throughout the day. So very small amount of radiation exposure. It helps to confirm the need for treatment. It's also a test that we screen every 2 years generally, so it can help us track any progression of bone loss and also predict your risk of fracture in the future. This tool, the bone density tool, is a better predictor a tool to predict risk factor is better than cholesterol levels to predict a future heart attack, and it's also better than blood pressure to predict a future stroke. So it's a really great screening tool and can be helpful in treating osteoporosis and osteopenia. What it is we take a scan of your lumbar spine, so the lower portion of your spine, and then we get a scan of your non-dominant hip and your non-dominant forearm. So if you're right-handed, we go on to the opposite side there. And these are just an example of these sites that are scanned, and we get T-scores, which is how we can diagnose you with those T-scores, and we'll talk about that on the next slide here. There you go. Sorry.
So the T-scores are based on a comparison to a huge database of young peak bone mass adults. So these are young women, ages 26 approximately to 30. And it's a huge database that all the bone density machines have incorporated into them. And so with every standard deviation away from that peak bone mass by that young population, there is a correlation of approximately a 10% loss of your bone density. So over time, or when it's assessed, we look at, how many standard deviations are you below that peak of when you were young, or when the average database was young. And when you get down below 2.5 standard deviations below that peak of a youthful person, we know that you have a 25 to 30% chance of breaking a bone with a sudden movement, an ordinary fall. We all fall, and we don't always break our bones, but your risk goes up dramatically as the bone becomes more fragile because there's less bone inside and there's less connectivity or struts holding your bone together.
And similarly, this just talks about specific T-score. So for example, if you had a T-score at, say, your hip of negative 1.5, you're about 15% below normal. So that just kind of puts that out a little bit detailed. Dr. Luca is going to talk a little bit overview of different treatments for osteoporosis. Go ahead.
As far as bone density, I know that test taken each and every time I ask why you only do one leg, because we have two.
Right.
And obviously, you can have a problem with one leg and not the other. And so I convinced her not to do my right leg, to do my left leg. And she hesitantly did my left leg only because years and years and years ago, I had my left leg done. So I was just wondering why they only do one leg when you have two.
So you only need two sites to appropriately diagnose osteopenia and osteoporosis. So generally it's the spine and then the hip. After about age 75, the spine becomes a little bit less reliable because there's a lot of arthritis there. So those numbers don't tend to be as accurate, and that's why we go on the forearm. So generally we go on the non-dominant side. It's technically your weaker side.
And the hips is less of an issue. Some manufacturers just say use your non-dominant side for your hip, and other manufacturers show both sides, and some average the two together. There's no consensus, and it hasn't been proven to make a huge difference.
You're missing a fifth, I think.
Well, tell me which one you're looking
Exercise.
at. Oh, did we not? Kayla did talk a little
Beverly
bit.
Ikea, I
Yes.
took her course.
She has a wonderful
Yes.
course.
I know you're aware of her because
Yes.
she mentions you.
Yes. No, she's
And
good.
she has stats, I think, to prove that without doing a drug, some people can rebuild.
I
and
know her
reverse.
claims.
Sure, that's her
Yeah.
claim. I'd like
Yeah.
you to speak to it at some point.
Well,
Because that would be
exercise.
the fifth one.
Yeah, exercise is wonderfully beneficial in trying to stimulate that bone cycle that participates in growth. I don't think any large-scale trials have been done where you have a group of conventional women and a group participating in that specific wonderful program to show that a difference over 5 years can be made. It probably will take 5 years, maybe even 8, to show a difference. There is tremendous variability in these tests. So interpreting whether you've improved or no change or decreased significantly is a little bit sketchy, and good facilities that understand what is called the least significant change of your machine, can avoid a lot of claims about change. It's hard to do these studies, and since there's no gain by an industry to do that study, it's hard to prove. But it's very important. I believe in it. I don't think personally it will ever replace the role for medications, but I do believe the two can help each other, and we shouldn't underestimate that. And the other piece about exercise is it can play a critical role in fall prevention, helping stimulate balance. And what we do know is the more you stimulate the muscle, it has a benefit on the bone health as well. In fact, we just started looking at body composition analysis. So there's data on muscle strength correlating with some bone strength. One stimulates and feeds off the other. So I think it's an area of active interest. I can't prove that claim, and maybe someday it will be proven, but it's a very good comment.
Is anyone taking it seriously in the field?
I think people are, absolutely.
Really study that to see?
Well, Tai Chi has been shown to, reduce fall risk, and I'm not sure fracture risk. So, there are things out there that people are looking at. But certainly stimulating muscle strength can help the bone strength. Stimulating balance can help reduce fall risk. And, it's an area of ongoing interest. The particular kinds of exercises I think they're trying to look at, and I think that Beverly's class pretty much emulates the kind of motions Kayla described on the machines. Abduction, adduction of the hips, leg straightening, presses. All those things that are going to stimulate all the muscles around your pelvic girdle are going to have a beneficial effect on that hip. So not to underestimate the effect of any modality, we just saved the medication for last, because sometimes by the time we even detect anything in our office, a lot has been lost. And so when osteoporosis is significant enough, not only should there be exercise and proper diet interventions and vitamin D supplementation, but there may be a need for medication to restore some degree of bone loss and perhaps reduce our future risk of fracture. Once you have sustained a fracture, your risk of a next fracture goes up dramatically. And so there's lots of data and use of certain agents, especially in a person who has osteoporosis and has already fractured once, of intervening at that point with medication to reduce the next fracture, and sometimes as little as 6 months. Now, these agents are not perfect, but nor is any other medication your doctor prescribes for you. So it's an individual conversation between you and your doctor, and the benefits and the risks for you as a patient. Estrogens used to be used and were protective of the bones and could stimulate bone mass and reduce fracture risk, including in the hip. However, because of the Women's Health Study and long-standing use and risk for other conditions like breast cancer, it's fallen largely out of favor. So to treat bones, many physicians will not choose to use estrogen as a way to treat bone loss or reduce fracture risk. And that's oral estrogen. Topical estrogen and estrogen by other means is not strong enough to stimulate bone growth. Bisphosphonates as a class, there's 2 popular oral ones and 1 intravenous one. These agents have been around and used in some patients as long as 10 years. Good and bad to that concept, and we have revamped how we use them to try and reap the greatest benefit and try to reduce the downside. And there are
names?
Alendronate or Fosamax, Resedronate, Actonel, and the intravenous is zoledronic acid, which is reclassed. You see a lot of these commercials, I'm sure, on TV. They should only put so much money into exercise as they put into these drugs, because it's important to learn. But anyway, so the bisphosphonates, the oral ones, over time they worked out that you could take them once a week in most cases. It has to be taken a certain way. The pill is not very easily dissolved. So if you don't take it right, the pill just won't work at all. So step 1 is only taking these pills with water first thing in the morning and nothing else around for a half an hour. You may not take any other pill, any other vitamin, any other food, any other drop of juice, no coffee, or the pill just won't work. And rule number 2 is the pill has to pass by way of gravity through your stomach and into the part of before the small intestine called the duodenum. And in order to do that, we don't want you to lie down. if you lie down within 30 or 40 minutes of taking this pill and it hasn't gotten to its destination, it could cause a burn, an irritation in your esophagus, worse than heartburn. And also, if people are taking them repeatedly over time incorrectly, chronic inflammation here may even be linked with esophagus cancer. So that stuff is being studied, and it links probably to method of administration and maybe some factors about the individual. So being really careful about that, reporting to your doctor if you're having any side effects, is an important thing to be aware of as a patient. If you have prior history of long-standing reflux, anatomic reasons, kinks or curves or problems with your esophagus, this may not be the drug for you, oral agents. However, there is an intravenous agent that bypasses that issue. There are other potential downsides before I tell you about the positives, but not to say that they don't exist, you should hear about them. One of them is a very rare condition called Osteonecrosis of the jaw. It presents as a dental problem of a major degree. There could be pain, breakdown, erosion of the gum, exposing, the bone underneath the teeth. It can look like an infection, but the dentists are very attentive to this problem, and it seems to be linked more to prolonged or excessively long use of the medication. The other piece is when this was first discovered, it was discovered in the context of cancer doctors treating myeloma and breast cancer and other malignancies to the bone. So those patients were receiving higher doses, and the bone of these people is not normal to begin with. So when you took out all of the cancer and myeloma patients, it was like extremely rare, like 1 in 10,000 to 1 in 100,000 patients when it will happen. Now, if you look at someone's risk of fracture who has advanced osteoporosis and choosing to receive the treatment, I think the risk of fracture over the next year or two of treatment is like 100 to 1 of the complication happening if they chose not to treat their bone loss. So you have to balance risks, which we talk about, with benefits. And there's one other area of a downside to this drug, again, when people were on them for 10 years at a time, and that's atypical breaks or bones in the femur, an area where no one breaks their bone from osteoporosis. And those are called atypical femur fractures. And again, it seems to be linked to excessively long use of the drug. The bone produced when we turn off all the diggers and builders are just building is pretty good. It's thickening the links, it's restoring calcium to the bone, and the bone is harder. It might either be more brittle than normal bone, and it maybe needs more time for normal addition of our own calcium, our own building mechanisms after the drug is withdrawn. Yes?
Bisphosphonates, where do they go into the cycle of building bone and breaking it down? Do they stop the class from breaking it down?
Yes, they stop the diggers, and they're not supposed to poison the builders.
I heard that these drugs, they do stop the diggers, so you keep holding on to bone that gets older and older and older and more brittle.
Yeah, so if you don't treat too long, that effect's not happening. So when those other cells are getting older, perhaps the drug is starting to affect the builders. So in other words, you're going to, the cells that are more susceptible to use of bisphosphonates are the diggers first. So it turns them off, and if you treat too long, it might start to turn off the builders a little bit so that they're aging instead of replacing themselves. So the goal is to find a good balance where you treat not too long, just enough to turn off those diggers, not poison the builders. And we've kind of adopted a new stance. No one stays on these drugs for 10 years anymore. We treat milder forms of osteoporosis for 3 to 5 years max. In the case of reclassed milder osteoporosis, would be treated for maybe 2 years max.
Well, what do you do then when we're living more like 20 and 30 years?
Well, we take a vacation. We take a vacation from the drug. And in fact, these drugs stay a long time in your body. So you will recover back your whatever, ill effects from the drug. You will recover back your normal bone remodeling. But the diggers stay quiet for a very long time. So there is still continued benefit of reduced fracture risk for 2 to 5 years, depending on which of these agents after you stop. So I will take people off after a standard course.
And the builders will start building again?
They will, and there's ways to test that besides bone density. There are urine tests and blood tests where you can look for markers that the bone remodeling cycle is resuming. And when it goes up by 25 or 30%, you know it's starting up again.
I had a question about reclass.
Yes.
That's a once a year infusion?
Yes, it is. And, insurance companies are a little bit different in terms of, they may insist that you have tried or failed or not tolerated an oral agent first. Others are not so picky, so it depends on your insurance.
I think too, like Fosamax, the medication adherence to that.
Any bad side effects?
Well, I don't know, I gotta go for another bone density if I have to have another one. No, you just feel like you get the flu,
Yeah,
but
Oh,
it didn't
yeah.
bother me.
Flu-like
No, it
symptoms.
didn't- Was fine.
that's most
Yeah, I was
common.
supposed to go last month and I got kind of sidetracked, so.
No, it only
Okay.
takes, what, 20 minutes or something?
Yeah, it's not a long infusion. It takes longer to put the IV in than it does to
Yeah.
give the drug, I think. So, but the bottom line about what you're talking about, it can cause a flu-like set of symptoms. I routinely have all people take a dose of Tylenol when they're there.
Yeah,
I
yeah.
warn them that this can happen. The literature says it can go on for 48 to 72 hours. I haven't seen that, and I've had one patient in 20 years tell me they spiked a fever of 101 within the first 24 hours. So it's real, but will pass.
Okay.
And the other literature says with subsequent infusions, that's less common. So,
Good to know.
so, take some Tylenol, stay extremely well hydrated, make sure you're taking adequate calcium during those first couple days especially, and most people can get through that just fine.
I think that's better than that other one, Priola.
Prolia.
That Prolia.
Uh-huh. So Prolia also turns off the diggers. It's actually turning off the activation of the digger. Is also turning off the maturation process of the digger. So it works in a slightly different place than the bisphosphonates. And it works like gangbusters. However, it's a short-acting drug. So after 5 years or whatever amount of time your doctor treats you for, this drug rapidly leaves your system. And there now are studies showing in people who are on this for a while that there's like a rebound, a rebirth of your whole remodeling cycle. And the first thing that happens is those diggers, which were turned off for 5 years, they're like really hungry. So they get in there and they start digging very quickly. And there's been incidents of vertebral fractures somewhat rapidly after 6 months of getting off.
Getting off what again?
Your denosumab, the thing,
Denosumab.
yeah,
Prolia.
which is Prolia. And
Prolia,
so
okay.
what they've now adopted with this new information, because it hasn't been out on the market quite as long as the bisphosphonates, is that we have to stabilize those gains made with the Prolia by hitting it with one dose of reclast or something to just stabilize it so that you don't lose all that benefit just because the body is rebounding from this drug which turned everything off for a while. So sometimes it takes 8 to 10 years of something to learn about later effects and how to mitigate or prevent certain things we did not anticipate. And so that's the case with Prolia. It's not been removed from the market. It has tremendous benefit. Sometimes in our hands, when we treat with the anti-resorptive agents, particularly the bisphosphonates, we see bone density going up and then it kind of plateaus. Now there's still lots of data during that plateau showing that future risk of fracture goes down, but I can't prove that it's correlating with the bone density going up. With Prolia, there seems to be less of that plateau, or it doesn't happen until later. So they do work a little bit differently. The results we see on bone density are a little bit different. And time will tell in terms of how to reduce any future risks. Osteonecrosis of the jaw has been described in Prolia as well, but it's neither more frequent nor less frequent. There's no head-to-head comparison because it's a very rare event. And then, I'm sorry.
Yeah, one question.
Oh, yes. This is a wonderful overview. I really appreciate your being here. My doctor is going to be talking to me about these drugs when I see her next time in November. My question is, in your experience, what increase in the T-scores of your women patients do you see, or are you mostly looking at halting the loss?
Okay.
With the use of your drugs. Let's talk about the bisphosphonates and the anti-resorptive.
Yeah.
What increase would you expect for a typical patient with osteoporosis?
So it depends on your apparatus in the center where you're testing and the least significant change of your machine. But in the real world, unless you see a greater than 5% change, it may or may not be significant. So you're looking for a greater than 5% change over the interval that you've repeated your test. And sometimes you don't even see quite that much in 2 years. But long before you see improvement of bone density, in as little as 6 months, there is data in people who have previously fractured that the risk of your next fracture is reduced like 40%, depending on which drug you're looking at. With reclass, it's sometimes 70%. That's a population of patients we know are going to fracture again, so it's easy to prove that. There is data on people before that first fracture who have taken treatment and been studied for 8 years, say, and there is data to show reduced fracture rate. The bone density itself, as I mentioned, the longer you treat, sometimes plateaus. So it's not good enough to show that a drug improves your bone density. You must always show that it's causing a benefit, a reduction in fracture risk, without hopefully a raise in another problem we did not anticipate. So many years ago, like 30, 35, they used fluoride. You know, fluoride's in your toothpaste. It helps the enamel and harden the enamel on your teeth. It actually improved bone density. But it turned out that people had increased fractures on fluoride because it stimulated bone growth that was disorganized. And so the bone that was laid down was not that nice, you know, interconnecting. It was kind of a mess. And the bone was fragile. And people had more fractures, even though this drug improved bone density. So in all studies, they must show that it's actually helping people in terms of clinical outcomes. It's not good enough to say, this helps improve your bone density. Is it improving normal bone or not? And that's an area of very active interest. People have to do in study, you know, academic centers, bone biopsies to see are we poisoning our cells and things like that. Let's see. And so estrogens, bisphosphonates, we talked about the prolia, and there are other agents on the horizon. How can we stimulate the bone to build instead of just turning off the diggers? What can we do to whip those builders to start making bone for us? And those are called anabolic agents. And one has been around for a while. It's very expensive. It requires an injection every single day. And when I can even get someone approved who has had severe osteoporosis with fracture, and if their insurance covers it, they don't want a shot every day. I've used it very few times. It can cause mild nausea or some dizziness when you stand, but that didn't happen in my hand. But it's just a difficult drug to get to patients. But there is data to show when you treat with this drug called teriparatide or Forteo, it can help stimulate builders of bone and help. And you can't treat these patients for more than 18 to 24 months, but if you do, and then hit them with these other classes of drugs to stabilize, there are further gains than if you skip that step alone, because you're helping build bone directly by stimulating the cells. When we looked at that drug in lab rats, there was an increased incidence of osteosarcoma, but the strength of the drug used in the animals was like 100 times what we do to humans. And no cases have been attributed in humans to this drug when used for a defined length of time at the dose we do. But again, it's not a very easily administered drug. There are newer agents, one called abaloparatide, which is closely related to Forteo, and I think it's once a month. Again, it's pretty new, and some of those risks are the same that I mentioned. I think treatment's only for a year to 18 months. And then there's an even newer one out there called romosozumab. And that one actually is working by a new mechanism in getting the builders to stimulate bone. And that's a whole new area where you're inhibiting a messenger in the bone called sclerostin, and by turning that off, you're allowing the builders to just take off. So there's many checkpoints, stimulators and checkpoints within our own bone, and all we're trying to do is, you know, inhibit one or stimulate another to get your body to build the right bone, and it's tricky, and you know, it takes a lot of time to prove that the benefit outweighs the risks. But again, remembering that we all know that shingles is a common problem in the community, and we're all scrambling to get that vaccine. Shingles is as common as a 1 in 3 chance in your lifetime, but a woman in her lifetime has a 1 in 3 chance of having an osteoporotic fracture. So I think it's just as important to remember, you know, we are doing such a good job with early detection of cancers, treatment of cancer, prevention of heart disease, treatment of heart disease, maybe preventing a few strokes by, controlling blood pressure and so forth. But what are we doing about our bones? We're all living longer because we've benefited from all those other interventions. But now we're living longer if we've ignored our bones. But we want to live better in the little time we have left. So I think it's time to pay a little more attention to that piece. Yes?
Reclassed, doctor convinced me to get a shot of that. Within weeks of it, I started having symptoms of osteoarthritis.
Pain.
And since then, it's continuing. And there's some linkage, isn't there, to setting, because you're talking bone here.
Yeah. Well,
And
there is
I was
spot.
I felt pretty angry about it.
There can be aches and pains. There is some belief, perhaps, are you getting enough calcium into your system? Is there any vitamin D deficiency at the time that you were treated? Because all those things can be stacked against you. When you give these drugs, particularly Reclass, there can be a dip in your serum calcium. It kind of turns off the release of calcium from the bone into the bloodstream, and that can contribute to aches and pains as well. So hopefully he can continue to work through, he or she work through that with you.
The osteoarthritis is continuing, and it's not something I wasn't told it could happen.
Yeah, I don't know that
I wasn't given a choice.
Yeah. Osteoarthritis is a separate disorder that is not proven to be caused by these agents, but joint pain is real.
Oh, so you're saying that this,
And it doesn't happen to everyone, but it can.
Osteoarthritis that I went to check to make sure it was that and not
Yeah.
rheumatoid or something else.
Yeah.
It has no direct linkage to Reclass?
No, but joint pain can ensue in the way that you described, even 2 weeks after an infusion. It's not common, but it is real. And in the literature, people are not studies, there is some belief perhaps these people are not getting enough vitamin D, not absorbing enough of their calcium, and there are disturbances in serum calcium, particularly in the first week or two, that some people manifest symptoms for and others don't. But there is no direct link of this to causing osteoarthritis.
So
It's a
you're
separate
saying
disorder.
that my osteoarthritis just happened to be coincidental at the time I took the Reclass?
Again, that's a process that was occurring over decades in your body. It didn't
Yeah, well,
suddenly
it's still
appear.
occurring.
But it's hurting more for whatever reason.
I see.
Yes, I took anastrozole for 5 years.
Yep.
And I just got the results of my bone density, and I now have severe osteopenia. T-score is -2.2, and my doctor wants to see me to discuss what to do. And can a case be made that when I have that T-score that I can build my bone by doing more exercise, or, because I'm not ready to go into the, medications. I don't want to start them at this point. And can I make a case saying that exercise, more weight-bearing exercise will help?
Can everyone hear? Okay, so I think, correct me if I'm wrong, the question was, this person completed a 5-year course of a drug that's an anti-estrogen, anastrozole. It can cause bone loss in breast cancer patients. A bone density was obtained that showed, as was put it, severe osteopenia. Osteopenia is less severe than osteoporosis, and there are other predictors of fracture risk in people with osteopenia. There's something called a FRAX score. So when you meet with your doctor, they can talk to you about your risk. Are you low bone mass, or are you low bone mass with increased bone fracture risk? And if you're in the latter category, there is some data to support treating. However, if you had ended your course, your body, through other modalities, might be able to gain back some. You can choose to wait and monitor. That's not a standard treatment, but understand your concerns. It's an individual decision between you and your doctor. Write your list of questions, and they'll give you their opinion.
Thank you.
All right, well, we probably have maybe one last question. All right.
We have some
Do you want to have
handouts.
a question?
Did you have a handout?
Maybe one.
Just about you said fluoride was bad, but it's in the drinking water. Does that have anything to do with
Well,
it?
in small defined amounts. We don't know.
Yeah, right.
No. I think they would have pulled it out by now, but it's in our
Right.
toothpaste. Yeah,
Well,
did they
thank you
have
very
them?
much to Dr. DeLuca and Kayla. Thanks. It was great.
She's the